Good afternoon. I'm Stephanie Moore, Project Manager of Provider Education for the Association of Community Cancer Centers. I'm eager to introduce Dr. Michael DeLeo as our expert presenter for the 10th e-course of the series hosted by the Institute for Clinical Immuno-Oncology, ICLIO. As you may know, ICLIO is an institute of ACCC, is the only initiative to prepare multidisciplinary cancer care providers for the complex implementation of immuno-oncology in a community setting. The ICLIO program provides a host of educational resources, tools such as webinars, newsletters, e-learning modules, tumor subcommittee updates, and ICLIO visiting experts and live meetings. Now for today's e-course. I am pleased to introduce Dr. Michael DeLeo, is a radiologist at Southern New Hampshire Medical Center. Dr. DeLeo has an expertise in breast and oncology imaging. He gained his fellowship in women's imaging at the Hospital of the University of Pennsylvania at Philadelphia. He attended and graduated with honors from University of Massachusetts Medical Center in 2009, having over 7 years of diverse experience, especially in diagnostic radiology. Now for a few housekeeping notes. Please feel free to submit questions to our presenter by typing our questions in the inbox on your dashboard. I will pose questions to Dr. DeLeo at the conclusion of his presentation. The webinar will be archived and available on the ICLIO website, accc-iclio.org. Now I'll send it over to Dr. Michael DeLeo to kick off the webinar.
All right, thank you for that kind introduction, and thank you for the opportunity to present this topic. And let's dive right into it. So next slide. So the structure of the talk is going to be in 3 different pieces. We'll start with reviewing the 4 patterns of response to immunotherapy, and I'll give a few examples of their imaging findings. Then we'll review immune-related adverse events and their respective imaging findings. And then finally, we'll dive into the role of the radiologist in caring for the patient on immune therapy. It's a challenging sort of new world out there of immunotherapy. We're used to seeing some things, sort of more passive immunotherapies, but with the newer active immunotherapies, there's a lot to learn, and there's a lot to learn quickly as this field is moving very rapidly. Next slide. I've provided a couple references which have most of the images that you're going to see throughout this presentation. Next slide. So just a very, very brief background about immuno-oncology. So we're used to traditional cytotoxic chemotherapeutics, which are essentially poisons that kill cells. Because tumor cells divide more rapidly than do other types of cells in the body, they tend to target these a little bit more so than hopefully normal cells in the body. So when we image patients that are on traditional cytotoxic chemotherapies, we're used to seeing very standard responses, which are typically used, the RECIST criteria are used, whereby we look at new lesions, any potential new lesions, and whether target or index lesions get bigger or smaller depending on the chemotherapies. This is staging and restaging of patients, and it has, we sit sort of at the center of clinical decision making because we're either calling progression, response, or stable disease. The therapies that stimulate the immune system are a little bit different in that they sort of allow the activation of naturally circulating T cells primarily that are then sort of revved up and can go attack tumor cells. And the focus here is going to be on ipilimumab, which is the human monoclonal antibody that blocks CTLA-4. And because CTLA-4 is a negative regulator of T cell activation, blocking CTLA-4 promotes T cell activation and tumor targeting. Some tumors, as people have found, research has shown, become so-called quote-unquote smart. And what they'll do is they will activate CTLA-4, which therefore downregulates T cells, and they sort of evade immune responses in that way. So that's how, very briefly, a 30,000-foot view of how ipilimumab works. Next slide. So as radiologists, I like to think of the molecular and cellular mechanisms that are going on that create imaging findings. So I just want to present this illustration of the sort of brown reddish cells on both images A and B are the T cell infiltrates that are infiltrating the skin on the left image and the bowel in the B image. And so that's exactly what's happening when you stimulate the immune system to attack tumors, is that these T cells, which are brown in these images, will go into the tumor and ideally kill it. And so this slide is the basis of what we see on imaging studies. So I think that's important. I'll refer back to this slide, so just keep it in the backs of your minds. Next slide. So as I mentioned before, measuring response to cytotoxic chemotherapeutics is relatively easy. We look for either new lesions, which automatically puts a patient in the progressive disease bucket, or we just measure the target or index lesions that were seen on the initial staging scan. And we do routine measurements of these, and we report the measurements with the comparisons, and we try to assess whether there has been, again, response to therapy, stable disease, or what that means is it equates to a treatment failure clinically. So the oncologist will typically change therapeutic options for that patient. Measuring response to immunotherapy is not so easy. We cannot use traditional RECIST criteria when evaluating patients on IO therapy. So I'm going to review in detail 4 patterns of response to active immune therapy that have been reported, and these are the accepted patterns of response that all radiologists should be very familiar with, especially when reading these type of studies. And as I mentioned before, we sit sort of at the center of the clinical decision-making process. And because of that, we really need to be aware of the emerging therapies that we may see in our centers. Next slide. So the first pattern of response I want to describe is just sort of pattern number 1, where you see a decrease in size of index lesions and no new lesions. Next slide. This is almost analogous to typical RECIST criteria response to therapy. And so I've got the images on the top. There are 3 images on the top, which are coronal PET images in a patient, and then there are 2 CT images and then fused images below those with the purple color. And what those are showing is the red arrow is pointing to a hypermetabolic or sort of the FTG-avid mass in the left chest wall, which as you move from left to right, you see that the blackness is decreasing. So we call that a metabolic response to therapy, and that's what we like to see. Now, the yellow arrow is pointing to new, quote unquote, new areas of FTG uptake in the middle coronal image of the PET study, and what that is showing is a sarcoid-like reaction, which is a typical, we call it an immune-related adverse event, but it's really just stimulation of the immune system. And so lymph nodes are now lighting up because the entire immune system is ramped up and lighting up lymph nodes. This sarcoid-like reaction resolved on the bottom right image following cessation of immunotherapy. Next slide. The second pattern of response that we see is clinically stable disease after completion of treatment. And this can have a long period of disease stability followed by decreased tumor burden. Next slide. This is an example of stable disease where the the 3 images moving from left to right, the bright black dot, say, in the center of the image is an enlarged lymph node, which is hypermetabolic, and over the course of several months doesn't change. So we would call that pattern response to clinically stable and imaging stable disease. Next slide. The third pattern of response is an initial increase in tumor size followed by a decrease in tumor burden. And this is theorized that as the body mounts an immune response, we see with a transient or temporary increase in tumor size due to the inflammatory cell infiltrates. Next slide. So this is a nice example from the radiographics article that I referenced, where the white arrow points to a subcutaneous mass that when your eye moves from A to B to C is getting a little bit bigger, and then from D to E to F gets a little bit smaller and nearly completely resolves. So that's what we see. That can be called sort of a flare response, and it's important to recognize this pattern because in the traditional RECIST criteria, this would be progressive disease because the target lesion is getting bigger. So we want to really be aware of the fact that this is not progressive disease. Next slide. Some lesions can get smaller and some can get bigger. The lesion, the arrow on the left, the two left arrows on each image show the decreasing size of liver lesions, while the two right-sided arrows on the two images show a splenic lesion, a lesion in the spleen, getting bigger. So this is a common thing, a common sight too, where you see what used to be called in RECIST terms a partial response to therapy, where you get some lesions that are smaller and some are bigger. Next slide. And then finally, the fourth pattern of response is when you see new lesions after completion of treatment followed by a decrease in tumor burden. This is presumed due to micrometastases not previously visualized due to T-cell infiltrate. So as the refer back to that slide of the images of the cells infiltrating, when more cells infiltrate, things become now visible. So the key here is it's not definitely a treatment failure. Therefore, we recommend a follow-up scan in 4 weeks comparing these lesions. So that brings us, next slide, to the immune-related response criteria, which were developed sort of in conjunction with these 4 patterns of response that we're seeing. Next slide. It's been described that we see either a complete response, a partial response, stable disease, or progressive disease. So the ideas are similar to traditional cytotoxic chemotherapeutics, but the key I just want to focus on progressive disease is that you have to really document what is considered to be a 25% increase in tumor burden at any time point, and that tumor burden stays elevated or still progresses even after several scans, say 4 weeks, 8 weeks, 12 weeks after therapy. So that's how it takes a little bit longer for us to call progressive disease when a patient is on an immunotherapeutic. Next slide. So it's been recommended that you do an initial imaging follow-up study after therapy and that you follow that up 4 weeks, 4 weeks later. That allows us to assess this potential for a delayed response or to assess the flare phenomenon, which I'll go into a little bit more detail in a few slides. Next slide. So a couple challenges that we face as radiologists and oncologists is that the immune-related response criteria do not specify the modality of follow-up. So you could do a CT, an MRI, or a PET-CT. And the IRRC does not assess tumor metabolism, which could be problematic because PET tends to be the preferred imaging modality because most of the patients that are on the IO therapies have advanced metastatic disease, and PET is really the best way to image the whole body and to really delineate all the lesions, especially since they light up on PET scans. So these sort of the immune-related response criteria are still evolving, and we look forward to hopefully maybe a little bit of clarification of which imaging modality is preferred and whether we can say that an improved PET-CT really represents a response to therapy. Next slide. for us, and everybody taking care of the patient on IO therapy, the key question is are we seeing a positive response to therapy? So is the patient getting better? Or are we seeing inflammatory change? And that is very tricky, and that's why we recommend this follow-up study really after 4 weeks. And so follow-up scans are recommended, and we recommend continuing investigation of novel PET tracers, which can hopefully help us in the future with delineating these things. Next slide. So instead of sort of the traditional RECIST criteria and WHO criteria, we're moving towards this IRRC, again, which allows us to continue therapy even if we see what could be considered progression of disease on a traditional scan. Next slide. So with any new therapy, closely monitoring the potential adverse events is very important. These can manifest themselves clinically and on imaging findings, so the radiologist must be well aware of the imaging findings of the adverse events, especially related to IO drugs, and we must communicate these adverse events in a very timely fashion because some of them are life-threatening. Next slide. I'll review briefly some of the immune-related adverse events that are more common, especially with ipilimumab. We see colitis, hepatitis, dermatitis, and some endocrine disorders, specifically hypophysitis. And most of them occur, during the 12 weeks of treatment. And it's helpful to know sort of what the median onset time of these adverse events is so that you can be well aware of them depending on the timing of the study. So we typically see the skin-related issues earlier than, say, the endocrine issues. Next slide. Colitis tends to be the most severe and problematic immune-related adverse event. And the main reason I want to focus on this one briefly is that the treatment is very important. So whether you give a patient antibiotics or steroids or both is a very important sort of treatment decision, and we can help with that. For the colitis, you can see diffuse colitis, meaning involving the entire colon, or short segments of colon involving this. And clinically, the patients will have watery diarrhea in diffuse colitis, whereas in segmental, you can get some bloody diarrhea. And anytime you get blood, you try to want to add antibiotics as well as steroids treatment. Next slide. Here's an example of segmental colitis on ipilimumab. So you see wall thickening of a segment of the colon, and so you want to be really looking for signs of potential perforation. Next slide. For example, on the left image, the purple arrow is pointing to a segmental area of colitis, which has perforated on the right image. So we really want to be looking out for those things and communicating these findings right away. Next slide. Autoimmune colitis is often hypermetabolic on PET scans, so you see diffuse uptake either in the diffuse or segmental distribution in the colon, and that can resolve on subsequent scans. So you want to follow these findings on subsequent scans as well. Next slide. Other immune-related adverse events include hepatitis. We'll see periportal edema, nephritis. We'll see renal enlargement. Next slide. Here's an example of immune-related adverse event of nephritis, where the next slide, please, where the kidneys, thank you, are enlarged, and you see reactive small bilateral pleural effusions on the scan in the lower left. And so those are, again, things to look out for as well. Next slide. I want to show a quick example of hypophysitis, which you'll see increased FDG uptake and pituitary enlargement. And again, just like most of these immune-related adverse events, they resolve or get better following steroids. Most patients are going to be on steroids anyway during the course of treatment. So whether you increase them or whatever they need, that's sort of the mainstay of treatment. Next slide. This is a PET scan of the brain on the top 3 images, and the bottom 3 images show a correlative MRI of the brain. And what we'll see is in the center PET image on the top, there's a black dot in the center, which isn't there on the other scans. That's the autoimmune hypophysitis, which basically shows hypermetabolism. Its correlative image in image number or image letter B shows enlargement of the pituitary gland, which has normalized both in FDG uptake and MRI appearance on C, and that's either following sort of cessation of treatment or use of steroids. Next slide. Additional IR AEs that we look for are pancreatitis, myositis, arthritis, a sarcoid-like reaction, and vasculitis. Next slide. Here's an example of autoimmune pancreatitis. Again, the theme here is the same. So it's not the specific imaging findings that I want to harp on. It's that you'll see a lot of PET scans here throughout the talk, and that's because, again, PET is a preferred imaging modality. So when we're showing PET scans, we're looking at black areas and then yellow areas on the images, and those are the areas of increased metabolism or FDG uptake, and those are the areas that we want to focus on. So the pancreas in the top right image is diffusely abnormal, showing increased FDG uptake, which again normalizes on subsequent studies. This is a very typical pattern of sort of a revved up immune system or immune-related adverse events that gets better with either cessation of treatment or steroids. Next slide. We can see arthritis. We want to be aware of this on a PET scan. We're looking in all the joints and looking for FDG uptake in all the joints, which in this case normalizes again after 2 subsequent scans. Next slide. A sarcoid-like reaction is where you see FDG uptake or enlargement of lymph nodes. They can be anywhere in the body. We're showing an example here of lymph nodes in the mediastinum, which are enlarged and hypermetabolic. And those, the classic sarcoid-like reaction is again in the chest. And if you remember the very first images that I showed you in the talk, we had the sarcoid-like reaction in a patient that had a complete response. And so we see that a lot, and we just want to be aware of it and call it, make sure that the referring physicians know that what we think is a sarcoid-like reaction is not disease progression or new lesions. We can see some uptake in the lung as well, which is also seen in the sarcoid-like reaction. Next slide. So I know most of the focus of the talk is on ipilimumab, but as the PD-L1s and the PD-1 antibodies make their way into the market, I want to mention that it seems to be that there are fewer, less severe immune-related adverse events with the anti-PD-1 and PD-L1 antibodies compared with the ipilimumab drug. And just in a recent phase 3 trial, grade 3 immune-related adverse events were about half as common with pembrolizumab versus ipilimumab. So just as a lookout to that, I think as we transition more into the pembro sphere, we may be seeing less frequent immune-related events. Next slide. Potentially one of the most severe ones that can be seen is when the mediastinal lymph nodes and or mediastinal disease gets so ramped up with cellular infiltrates that they get so big that they start compressing normal structures that they shouldn't be compressing. So in this example of the flare phenomenon, where you just see everything, sort of the index lesions getting bigger, what you'll see is the narrowing of the airway or the trachea, and in this patient, she required tracheal stenting. So that's a severe, life-threatening potential thing to look out for, is the flare phenomenon. Next item. All right, So those are all the imaging slides, and those are there for reference too. And I want to switch gears a little bit and just talk about our experience at Southern New Hampshire Medical Center and my perspective about how we take care of these patients in our center. So we are a sort of medium-sized hospital in the region of Southern New Hampshire. We are a clinical affiliate of Massachusetts General Hospital. We have 3 MGH oncologists who see patients at our hospital, and those patients are enrolled in clinical trials at MGH, and those trial patients typically get their imaging at MGH. However, as immunotherapies move out of the trial phases and into regular practice, that's how we've started to see these patients being scanned at our facility. And these patients who are not on trials can get their imaging anywhere. So we try to get them seen regularly, at one place so that all the prior studies are there and you can compare and really increase the quality of care that you deliver to these patients, because their care can be fragmented as they move from one facility to another. Next slide. I think it's very important that we all know each other well, because I think that confidence in our colleagues is very important. It makes you comfortable picking up the phone and asking questions of your colleagues, and it's a two-way street. So the oncologists call us all the time and we call them because we want either more clinical information or they want to clarify imaging findings. And the best way to really meet and get to know everybody well is to sit in the multidisciplinary conferences, which nearly every hospital has these days. We have a sort of a bi-weekly cancer conference, and we discuss patients that are on immunotherapies and those that are on traditional cytotoxic therapies. And we review their images and we review their pathology, and together we make clinical decisions sort of on the management of these patients. And so it's important for us to know what trials are potentially available to the patients at our facility, because we do have some trial patients that, even though we're a small community hospital, we do have some trial patients that do get their imaging at our facility. So it's important to know who those patients will be, and talking with your colleagues is most important. With more small hospitals teaming up with academic centers, I think that this is most important, because again, you're going to start to see patients that are traditionally seen only in the tertiary centers making their way back more into the community, which I think overall is a good thing. Next slide. We find it very important as radiologists to have a very good history. So when a patient is on active IO therapy, we need to know that, because if we don't, we'll call it disease progression, and that'll be the wrong that'll be the wrong reading to provide our clinical colleagues. So what we've done at our center is, again, at one of these multidisciplinary conferences, we discussed the issue with history, and we've brought it, and the oncologist brought it back to their office, and they made it a policy that they tell us every patient that's on IO therapy right in the history line, and they give us medication lists and medication histories on other patients so we can review those as well. We found that to be critical in providing them with accurate reporting. I think that oncologists and radiologists should try to come together and try to come to a consensus about appropriate imaging modalities, whether it's CT, PET, or MRI, and follow-up intervals. And again, there are some guidelines, for example, rescanning a patient 4 weeks after the initial therapy is stopped, but subsequent studies or subsequent stagings are not as well delineated, and again, whether you do a CT, MRI, or PET is important for comparison purposes. So if at all possible, try to come to a consensus about these, about how we're going to follow patients. Next slide. So our experience is we're a group of about 9 radiologists, and in this group of that size, it's hard to have every reader be up to date or totally invested in reading these type of studies, which are often complex, multiple prior examinations, lots of imaging findings, and sick patients. So it's possible to consider having dedicated readers for patients that are on IO therapies and other cytotoxic therapies. That's one consideration that could be given. We do this at our facility. All caregivers should be well versed in both RECIST and IRRC. Again, they know everyone is on the same page about what we're talking about. We want to also talk with our oncologists and ask, what do they want in a report? And that's a really key feature of sort of the multidisciplinary approach, is we want everyone, again, to be on the same page and to be speaking the same language. Next slide. Since only a limited number of the active immune therapy agents are currently on the market, we should be all familiar with their individual side effects. And for us, again, those that manifest on imaging studies, the IR adverse events that I reviewed, and we must communicate any potential adverse event immediately to the team. As I've showed you with the colitis and the flare phenomenon, some of these are immediately life-threatening. Next slide. I think it's important to note that as we partner with academic centers, the complexity of patients that we see in the community is probably going to increase. We're going to see trial patients. We're going to see patients on drugs that we're not as familiar with as they are at the academic center. So that's a challenge for us as radiologists and as community providers to really try to stay up on the latest research, the latest drugs. And so whether we see them on and off trial is important. Access to prior imaging studies for trial patients is a challenge. Oftentimes, we try to get all of the studies into our facility and into our PACS system so that we can make comparisons and be accurate with our reads. That's another important thing to mention. Next slide. So I think that as more therapies enter the market, and the imaging needs are going to change. And the question for us in the community is, how do we adapt to these changes? How do we adapt to seeing more complex patients on different types of drugs, newer emerging therapies? And can we, as community hospitals, offer the technologies that are needed really to treat and follow these patients? At our facility, we have a truck-based PET scanner that drives to our facility once a week, and we schedule all of our PET scans on one day. And that seems to work based on our clinical needs at the moment. But as our needs increase, are we going to be able to scan all these patients in a timely fashion? I think that's an important concept. The concept of potential steerage in the insurance market, again, just to briefly note this, has the potential to fragment care as patients may go towards the lower cost imaging facilities. As more and more high deductible health plans enter the market, patients have more skin in the game, so to call it, and they may choose lower cost imaging centers, which may fragment their care and make comparisons with prior studies a little bit more challenging. So that's just one thing for us to, again, just keep on the radar, look out for, and monitor closely. So I'd like to wrap it up at this point and take any questions that anybody may have.
Well, thank you, Dr. DeLeo, for that engaging presentation. And I do have a couple questions from our audience, starting with the first one. Have you noticed a difference between the checkpoint inhibitors, the CTLA-4 inhibitor versus the anti-PD-1, anti-PD-L1 inhibitors in regards to the pseudoprogression? Do you observe more pseudoprogression in one type of checkpoint inhibitor versus another?
So far, boy, that's tough. I haven't noticed anything, any huge difference. So pembrolizumab is sort of the big anti-PD-1 drug, and it's more active than ipilimumab. So in theory, pseudoprogression could be more common because it may rev up the immune system potentially in a different way. And so this would bear out on imaging studies, and I think that the trials just need to keep reporting the flare phenomenon and its frequency and its comparison as with older drugs or other drugs, and especially as people try combination therapies as well. They're doing CTLA-4 inhibitors plus anti-PD-1 inhibitors, and again, that's just going to get more and more complex. And in theory, the flare phenomenon would be more more common. The flare phenomenon in and of itself is unpredictable, and it really depends on a patient's immune system itself, and again, what if they're given steroids and how much they're given at the time of treatment. So it's a complex, very, very complex and unpredictable phenomenon, which bears we look forward to future reporting in trials.
And then for our second question, you have shown cases of patients with immune-related adverse events, colitis, nephritis, and pancreatitis, etc. Following treatment to manage the adverse events, how long do you wait before performing the next scan to assess whether the supportive care agents is working?
Yeah, that's a good question. Usually with the immune-related adverse events, the patient will, we hope, be symptomatic so that clinically you can identify them. Now, some of them may not be, and that's where we collaborate with our clinical colleagues and work together to try to determine if what we're seeing is a true immune-related adverse event. I think that most of these patients are probably followed on a symptomatic basis once a diagnosis is established, and therefore, as long as an accurate diagnosis can be established up front, either clinically or with imaging or with both, then I would probably stick to a usual cancer imaging follow-up with you probably don't need to do a scan specifically to monitor the adverse related or the immune-related adverse event. Those can be usually followed clinically, and if there is, say, worsening of the symptom or deterioration of the patient clinically, or new symptoms happening, then I think rescanning those patients, usually with a standard CT scan of usually the abdomen and pelvis with contrast, is probably the best way to do it. But I think there's fairly little need to document resolution or improvement of the immune-related adverse event as long as the patient is doing well clinically.
And then for our final question, can you describe in more detail your interactions with the multidisciplinary oncology care team in general? What is the extent that the radiologist interacts with the pharmacist, nurse, and hospital administrators?
Yeah, this is a challenge, I think, for a lot of people in the healthcare system. Our care it's fragmented a lot of the time, and we're all siloed in different areas. And some centers are really trying to address this issue by making, say, in a cancer center, you have oncologists, you have surgeons specific to oncologic surgeons, you have oncologic radiologists, you have oncologic pharmacists, you have nursing, all in the same physical space, so that, say, when a patient is seen in the office, they get their scan, there can be potential for direct face-to-face interaction between the radiologist, the oncologist, anybody, the nursing staff, and that as part of that team. A challenge that we face, and a lot of people face these days, is that we're not in the same physical space, and it's a big challenge to really have good communication of what we're seeing, what the patients are like, and a lot of times we read scans that are, the histories are what we get, and they're brief histories, and I think that it's a challenge to really get an idea of what the patient looks like physically, how they're doing clinically. So we try not to read in a vacuum as much, And so I think that having people in physicals is sort of redesigning care into these physical spaces where everyone caring for a particular patient is together is a good way to go. And a lot of centers are trying to do this. And I think as bundled payments become more and more common and alternative payment models, I think that could really benefit everybody, the patients, the health systems alike. So we unfortunately have fairly limited interactions with, say, the pharmacist, the nursing staff, and that's because they're physically in the oncology office and we're physically not. We could be in a completely different building or on a completely different campus in some situations. So I think this emphasizes the importance of being visible at these multidisciplinary conferences, because those are the times when the oncologist, the radiologist, the pharmacist, the nursing staff, and sometimes hospital administrators are all present in the same room. Now, unfortunately, we get 1 hour every 2 weeks to do something like that, but we really value that time, and so that's really when just being physically present at those conferences is really the most important thing I think we can do. Relationship with the hospital administrators varies, I think, from place to place and from person to person. I think our relationship with our hospital administrators is very strong, and we work together to try to provide the best care we can for the patients that we serve in our community. And so I think there's, the future is looking bright for both hospitals, systems, and patients alike, and a more collaborative, physical space or all-together effort is going to be good for all involved in care.
Well, thank you again, Dr. DeLeo, for that engaging presentation, and thank you to the audience for participating. The webinar and slides will be available on our website at accc.iclio.org shortly, and all the registrants will receive an email with a link. Please also register for our next webinar installment on December the 5th, where Dr. Sigrid Hellmeyer will present on immunotherapy, how to model your emergency response to triage in IO patients. Thank you, and enjoy the rest of your week.
Thank you very much.
Thank you.